Okay, so how are we going to attach the appendicular skeleton to the axial skeleton? The way that we do that is through the pectoral girdle and the pelvic girdle. And as you can see there, the pectoral girdle is going to attach the upper limbs to the body trunk or the axial skeleton, and the pelvic girdle will attach the lower limbs to the body trunk or the axial skeleton. The pectoral girdle is going to be called the shoulder girdle, and basically it's going to consist of the clavicles and the scapula. They're going to attach the upper limbs, which will be the humerus and the forearm bones and all the hands, to the axial skeleton. And in this particular case, we're going to have a lot of maneuverability in our shoulders, much more so than we have in our lower extremities. And so you're going to sacrifice stability for maneuverability in the upper extremities. So the pectoral girdle, as they said a second ago, consists of the clavicle, which is also called the collarbone, and all the scapula, which is called the shoulder blade. And then if you look at that picture right here, the only part that really attaches to the axial skeleton is the clavicular, or the clavicle, where it attaches to the manubrium there. And then the scapula is just the floating bone that goes over your rib cage. So the clavicle consists of two parts that you have to know. One is going to be a flattened portion, which is going to be the acromial end, and the other part is going to be the sternal end, which would attach to the manubrium. That is it, two parts. The flattened end, which is the acromial end, and the non-flattened end, which is the sternal end. And if you feel in your own neck, you can kind of feel that there's a bump where your shoulder, where your clavicle meets your sternum. The best way to teach the scapula is I would find the posterior portion. So here is going to be the posterior portion, and I always start with the spine of the scapula. Even though it just says spine there, it is the spine of the scapula because there's lots of places that have spine in their name. And so the spine of the scapula, if you follow that right to the end, goes to either the acromion or the acromion process. The other thing that's sticking out is called the coracoid process. So the acromion is going to be attached to your collarbone, clavicle, and then the coracoid process is going to have a muscle attached to it, or a tendon from a muscle. But by finding the spine of the scapula, you have an indent above the spine and you have an indent below the spine. So just thinking about our basic anatomy, above the spine would be called supraspinous, and the indentation is called the fossa. Below the spine is called the infraspinous, and it's also an indentation. So that landmark is the spine of the scapula, and you have a supraspinous fossa above it and an infraspinous fossa below it. On the anterior side, where there is no spine, you are going to have another fossa. This whole thing here is going to ride on top of your rib cage. And that's why you can take your arm and move it forward, move it up and down and stuff like that, because this portion is floating on your ribs. If you notice here, there is an area where we're going to attach your humerus to, and that's called the glenoid cavity. You can kind of see it better from this anterior view than you can from the posterior view, which is here. So the glenoid cavity, which is going to be out lateral, is then going to have the arm attached to it there. You notice that there's a little notch at the top of the scapula, and so just using our anatomical terms, you can see suprascapular notch, which describes it perfectly. There's a notch on the top of your scapula, and its name is called suprascapular notch. Then you're going to have an angle at the top, which is called the superior angle. You're going to have an angle at the bottom that you can't see on this one, which is going to be called the inferior angle. And then there's also a superior, the inferior angle, and then there's also an angle if you went across this way to here, and that's called the lateral angle that you don't even see in this particular picture. But you are going to see the border. The one that goes out towards your armpit is called the lateral border. This border here, which is the medial one, because your spinal column would be right there, is called the medial or vertebral border. That's basically the parts that make up the scapula. It looks like a triangle because it is the shape of a triangle, as you can see here. Here is the coracoid process, and here is the acromion, which is going to be attached to the clavicle. So you can see all of the borders. There is a superior border across the top. There is a medial border towards the spine. Here is the lateral border that goes out to your axillary area or your armpit. The suprascapular notch is the notch on top of the scapula. There is a superior angle here, an inferior angle at the bottom, and then of course there'd be a lateral angle there. So that is everything that you have to know about the scapula and be able to identify. In this particular picture, you are looking from your body, looking out towards your arm, and you can see that the glenoid cavity is not a really big cavity as we will have when we finally get down to the lower extremities, because you want to have the ability to make your arm go up and over to the side and sometimes reach around and scratch your back. So the glenoid cavity is very shallow, and by having that shallow appearance, you have the ability to maneuver or manipulate your environment, whereas in your lower extremities, you're just going to have it more for stability. So that means we're going to attach the upper limb to that scapula, and there's, as it says there, 30 bones more or less that will make the framework for each upper arm. In each side, you're going to have one humerus, that is your upper arm bone. The forearm has 2 bones in it. The thumb side is going to be the radius. The pinky side will be the ulna. And then there'll be 8 bones that make up your carpal or your wrist region. Then there's going to be 5 bones that make up your palm. And then each of your digits are going to consist of 14 phalanges, which is the bone name of it. So you'll see that both your feet and your arms are most of the bones of your body. As a matter of fact, of the 200 and some bones that you have, there is close to 100 bones that are in your wrist and your hands and your ankles and your feet. So let's just start with the humerus. The humerus is going to be the bone that's going to articulate with your scapula at the glenoid cavity, and then inferiorly at the elbow it'll articulate with the radius and the ulna. Let's just go to the picture and then I'll explain all of this. So if you look at this, it is the humerus. There is a head on the humerus, and then it's going to go all the way down here to the elbow at the bumpy portion there. So the head, just starting at the top, is just a head. It's going to have a narrower neck underneath it. And in this particular case, underneath the head of the humerus is the anatomical neck. And I'll explain why there's 2 necks there. So up at the head is also going to be 2 bumps. The bigger bump is called the greater tubercle, and the littler bump is called the lesser tubercle. In between those 2 bumps is going to be a groove or a sulcus. And so it is called the intertubercular sulcus on the anterior side. So basically you got a bigger bump here and a littler bump here, and then you have, I think when I hold that up, it looks like a sighting mechanism, and you can see down it. And that is called the intertubercular sulcus. So I'm going to get back to the necks. By definition, an anatomical neck is going to be narrower than the head, and you can kind of see in that picture it is going to be a little bit narrower. The reason that you have a surgical neck is because when kids break their arm, they don't usually break it up here at this big knob of bone. Sometimes they break it here, but if you have gotten to this portion in the lecture part, what's going to happen is there is going to be this portion here at the surgical neck. This is already going to be bone, this is going to be bone, but this portion and this portion here is still going to be hyaline cartilage. So what can happen is if you fall off of your skateboard and you put your arm out, that is where you usually would break your neck or break your humerus, or essentially you would be breaking your the neck of your humerus, and that's why it's referred to as the surgical neck, because a lot of times you have to have it surgically repaired and pinned back together. The bad thing about that, as you continue to grow, one arm or humerus particularly may be a little bit shorter than the other side, which is grown without having broken it. So a couple other things, we're going to work our way down towards the wrist. This area here, which is a roughened area that you can see a little bit better here on the actual bone, is called the deltoid tuberosity. So on this model here, if there was a deltoid muscle capping your shoulder, it would kind of attach, a direct attachment right to the bone there, about a third of a way down, and it's called a deltoid tuberosity. The radial groove is something that you normally don't see real well on the plastic models that we would have in lab, but it's going to be in the mid shaft there, and it's just going to have the radial blood vessel going through it and radial nerve too. As we go down to the wrist has this part here, which looks like, and this is from the anterior side, it looks like an upside down hourglass. The hourglass is going to be made of two parts, the trochlea, which is going to be the hinge portion that will allow you to bend and extend your wrist, and then this part here, which is called the capitulum. It looks just like a ball bearing. So the other thing that I can point out, if you find the head and then you drop down at the elbow, and this one sticks out quite a bit, the medial epicondyle is going to be the one that sticks out quite a bit. If you look on the posterior side, you can still see it, but the lateral epicondyle, which is not on the same side as the head, is the way that you can tell whether or not it's medial versus lateral. So the lateral just kind of sticks out a little bit, and the muscles on the back of your forearm make an origin there. And then you can see the medial epicondyle, which would be on the head side. That's going to be the one that sticks out quite a bit more. So the capitulum is going to receive the radial head, and the trochlea is going to receive the trochlear notch. And once we get to the forearm, I'll explain them. The other thing that you need to know is, as you're working superior from the trochlea, because there's a coronoid process on it that makes it a hinge, you really don't want to bang two bones together. So there's an indent there. And the indent is called the coronoid fossa. Because the head of the radius is kind of like a nail head, and it's going to be a little bit wider, that head portion of the radius, which is on the thumb side of your forearm, goes into a little notch there so you don't have bones banging into them, and that's called the radial fossa. And that's all on the anterior side. On the posterior side, because there's going to be an olecranon process going into an olecranon fossa, that is why you have a bigger indent on the back side of your elbow than you would have on the anterior side. So the book that I'm using right here kind of shows a couple ways that this goes together. Here is the anterior side here, and you can kind of see this indent here, and that's going to receive the coronoid process of the ulna. And here's a little indent here above the capitulum, and that's going to receive the head of the radius, which is a little bit wider than the shaft. On the back side, you can see that this indent here, which is the olecranon fossa, is going to receive the olecranon process, or just the olecranon, and that's the back side of your elbow. You can also see this medial epicondyle here and a little bit of a lateral epicondyle here. So here is the ulna, and here is the radius. So it's just a matter of knowing what the names of these parts are, because the test, when I finally give it to you, is going to have all of these lines gone, and all the words will be gone also. So that brings us up to the bones that will actually make up your forearm. And if you read this here, the ulna is going to be on the pinky side, It is the only one that is going to actually participate in making the hinge known as your elbow. So when you bring your palm facing forward up towards your bicep, that's the anatomical position. The action that you're doing is called a flexion. If you extend it back out, that is called an extension. All of that takes place between the olecranon process of the ulna and the coronoid process of the ulna as they meet up with the humerus, forming a hinge, basically. The radius is just going along for the ride. The only thing that the radial head does is going to be responsible for going from a movement which is known as palm up, and then you flip it over so that your palm is down. That's going from supination to pronation. So all of that, you can, if you have your forearm in the anatomical position with your palm up, you can bend at the elbow, which in the gym would be called a curl. Or if you have your palm up and you rotate it so that your knuckles are up, you can still do a flexion at the elbow, which in the gym would be called a reverse curl. So here are the bones of the forearm, and you can see them individually. Here's the anterior side, here's the posterior side. Here is this trochlear notch, because that's going to ride on top of the trochlea, which is the hourglass looking like thing here. The capitulum, which is going to be off to the side, is going to just receive the head of the radius. So this head here that makes it look like a roofing nail has an indent, and what's going to happen is the head is going to ride on top of the capitulum, and that's going to be responsible for the action of having your palm up or your palm down. So one of the things that I'm going to point out, you can see the coronoid process and the olecranon process, and they're going to be around the trochlea, and they make a hinge, just like you would have in the inside portion of your door so that the door can open and close. The hinge is going to allow your forearm to go up and down, which is called flexion and extension. One of the other things that you should note is that you want to keep these two forearm bones really close together and not kind of flaring out. So you're going to have a notch. On the ulna, you're going to have a radial notch so it gets really close. On the radius, you're going to have an ulnar notch, so it kind of flip-flops. So in order to keep the ulna close to the radius, you are going to have an ulnar notch on the radius, and in order to keep the radius close to the ulna, you're going to have a radial notch on the ulna. It's just kind of a flip-flopping back and forth. The rest of the ulna, as you go down towards the wrist, basically here's the shaft of the bone, and then down at the wrist, you're going to have the ulnar notch that I just talked about, and then you're going to have a pointy thing at the wrist, which is called the ulnar styloid process. On the radius, there's not a whole lot of parts that you need to know. There is the head, and underneath the head is usually called the neck, and then there is a part sticking out here on the anterior side, which is called the radial tuberosity, which will basically have a tendinous attachment from your bicep brachia muscle to here, which once you contract your bicep, you can pull your forearm up closer to your shoulder. So the radial tuberosity is going to be a bump that sticks out, and that's pretty well known. And then down at the wrist, you'll have the ulnar notch on the radius, and then you're going to have a pointy part, kind of you can see it posteriorly a little bit better than anteriorly, that is going to be responsible for your carpal bones and holding them in place when we finally get down to that. So the forearm doesn't have a whole lot of bones, it just has two. The pinky side is going to be the ulna. The ulna is the one that's going to have a way to make a joint at the humerus, and that is where the trochlear notch goes into the trochlea. And the radial side is going to be the thumb side. Although it doesn't participate in flexion and extension at the elbow, it basically is going to be responsible for being able to rotate it from palm up to palm down. Here's a couple other pictures that show how it's kind of put together. And if you look at this portion here, you can see the trochlear notch. Remember, it's going to ride on top of the trochlea. One part of the hinge here is going to be the olecranon or the olecranon process, and the other part is going to be the coronoid process. The radial notch is going to allow the radius bone, which is the one on the thumb side, to be right next to it. And then down at the wrist, you can kind of see here is the ulnar styloid process. And that would allow for you to have your carpal bones joining into and making a joint called the wrist. So what we're going to do now is just go through this portions of the wrist and then portions of the finger digits. So if you look at all of these bones, each of these are going to be responsible for a bone. So here is our radius on the anterior side. Here's our radius on the posterior side. There's only two bones that make up what's known as a true wrist. They are going to be the scaphoid and the lunate. And so you can kind of see that these are the only two that make a joint with the radius. And if we go back a little bit, you can kind of see these here are going to be where the carpal bones will indent to. So there's a lot of different ways to learn all of these, but my mnemonic for remembering that is some lovers try positions that they can't handle. So each one of that mnemonic, which is the first letter of the word that we're going to do, so some lovers would be scaphoid and lunate. Try position. So the interesting thing about the triquetrum and the pisiform, it is not in a row. It is actually the pisiform is on top of the triquetrum. I think they do have a picture where you can actually see that. No, they don't. Never mind. Okay, but anyway, it's not a row. It is going to be scaphoid, lunate, triquetrum, then pisiform. Then on the distal portion, which means closer to your fingers, try position. Some lovers try positions that they. That portion is the trapezium, which will go right to your thumb. That they is the trapezoid. And then this one here, which is in the middle, is the capitate, which will go right to your third metacarpal bone. And then 4 and 5 will go to the hamate bone. So the hamate bone is right here, and you can kind of see 4 and 5. They just use the Roman numerals, but it just 1, 2, 3, 4, 5. So if you just follow this from the anterior, one way to remember all of these bones is each one of your finger bones goes to a specific carpal bone. So your thumb bone goes to the trapezium. Your index finger metacarpal goes to the trapezoid. The middle finger metacarpal will go to the capitate, and 4 and 5 will go to the hamate bone. On the hamate bone on the anterior side, you can't really see it, but there's a hook of the hamate. So you could see that on the hand models in the lab. So that's one of the ways that I usually teach in class. How do you know what bone goes to which carpal bone? The easiest way to think of it, follow the bone here, and the first one there, which is the thumb bone, will go to the trapezium. The second digit will go to the trapezoid. The third one goes to the capitate, and then 4 and 5 will go to the hamate. That's on the anterior side. Same thing on the posterior side. 1 goes to the trapezium, 2 goes to the trapezoid, 3 goes to capitate, 4 and 5 will go to the hamate. So that's one way to figure out which carpal bone goes to which metacarpal. And so the metacarpals are, you always start with the thumb, first, second, third, fourth, fifth metacarpals, or thumb, indexed, middle finger, ring finger, and pinky, if you want to use the lay language. So as you're looking at that, don't worry about the head or the base or the shaft of the bone. I won't ask you anything about that. I just want you to know that this is the first metacarpal, this is the second metacarpal, third metacarpal, fourth and fifth metacarpals, respectively. As we go out to the phalanges, remember there's 14 bones that make up the phalanges. They are going to be labeled according to what we learned that first day, proximal, middle, and distal. So the thumb itself only has a proximal and a distal. It does not have a middle. So if you count them, here's the thumb, 1, 2, proximal and distal. And then the second finger would be proximal, middle, distal, proximal, middle, distal, proximal, middle, distal, proximal, middle, distal. So if you count that 3, 6, 9, 12, 13, 14, you got 14 bones that make up your fingers, which will allow you to manipulate your environment. So just keep in mind that the proximal phalange of the thumb is going to be right next to the first metacarpal, and then the distal one, which is going to be out this way. So your fingernails would be out in these, although these are just bones. There's no fingernails on bones. So we're going to have proximal and distal for the thumb. We're going to have proximal, middle, and distal of the second digit. And then I'm going to go right to the fifth one, proximal, middle, distal phalanges or phalanx, that's the singular of that, of the pinky bone. So you can kind of see when you put this puzzle all together that the true wrist consists of the scaphoid and the lunate. They're both attached to the wrist. And then the triquetrum and its knob on top of it, which is the pisiform, don't really make up the true wrist. And so a lot of times if people fall, these are the bones that they're going to be breaking because they're not really forming a joint with the radius. So that takes care of everything that we have for the upper extremity. And I'm just going to, in the lab, what I would normally do is start with the foot and work my way up to the pelvis. But in this particular presentation, I'm just going to go in the sequence of the order that I have them. So the pelvic girdle is what's going to attach to the axial skeleton, and we'll get through all of that. So basically the hip girdle is going to be attached to the axial skeleton through two hip bones. They are called the coxal bones or the os coxae, and then the sacrum. So if you remember the sacrum, it had an ear, which is the auricular surface of the sacrum. It's going to be attached to the auricular surface of the ilium. And there's three bones that make up these coxal bones. They are the ilium, the ischium, and the pubis. And then there's going to be a deep hemispherical socket, which is going to allow you to have your femur or lower bones attached to the pelvis. So here is a picture of what we're talking about. Here is going to be the pelvis bone here. Here's the ilium, the ischium's going backwards, and here's the pubic bone. And if you look at the sacrum here, this portion here is called the auricular surface, which means the ear of the sacrum, and it's going to attach to the ear of the ilium, and we're going to make a joint which is called the sacroiliac joint. And then anteriorly, because this is a ring, we're going to have a pubic bone on the right attached to the pubic bone on the left, and we're going to put a pad of fibrocartilage right in the center of it, and that's called the pubic symphysis. So the best way to try and learn this is kind of go around in a circle. And so this is the example that we would use in the lab. This is the lateral view, because remember, it's got to be lateral because this deep hemispherical socket is going to have a femoral bone attached to it right here. But I'm just going to go around in a circle because that's the easiest way that I have found to teach it, and just talk about the bumps on the bone-colored bone, which is called the ilium. The purple-colored bone is called the ischium, and the red-colored bone is going to be the pubis bone. So remember, the acetabulum is going to be formed from the indent of the fusion of these three bones together in the center. So I'm just going to go around. So each of these are called an iliac spine. So this one here is in the front, and it's called the anterior inferior iliac spine because it's in the front and it's on the underside of it. The next one is we're going to go in and then come back out, and at the end of the iliac crest is going to be going anterior, the anterior superior iliac spine. In the notes that I gave you, I abbreviated as ASIS. The A and the S stand for anterior and superior, and all the IS's stands for the iliac spine. So as you go around in a circle, anterior inferior iliac spine, anterior superior iliac spine, which is at the end of the iliac crest. And if we follow the iliac crest, which is your hip bones, all the way to the posterior side, there's going to be a bump sticking out, which is called the PSIS, or posterior superior iliac spine. We're going to have an indent and then an outdent. And I made that word up, and that's called the posterior inferior iliac spine. That's how you can tell anterior from posterior. Then we're going to have an indent here, which is a big indent, and that's called the greater sciatic notch, and your sciatic nerve will come out of there. Then we're going to have something sticking out a little bit here in the purple portion, which is called the ischial spine. So we're going to have the greater sciatic notch, the ischial spine, a little indent here, which is on the purple also, and it's called the lesser sciatic notch. And then we're going to have the bump at the back of your butt, and it's called the ischial tuberosity. So the ischial tuberosity, if you feel around to your own bump, is enlarged because you're going to have your hamstring muscles attached to this thing. And if you remember Wolff's Law, it says a muscle's going to, or a bone's going to increase in size if there's a pull on it. And so everybody is going to have a pull as they're learning how to walk and stuff like that. So just recapping, explaining this coxal bone. I always start here, anterior inferior iliac spine, in and back out. That's the anterior superior iliac spine. We'll follow it all the way along the top, which is what you can feel on yourself, and that's the iliac crest, which will end the crest posteriorly at the posterior superior iliac spine. We'll have an indent and then an outcropping, and that would be the posterior inferior iliac spine. This portion right here, which is the big indent, is the greater sciatic notch. Down here in the purple, that's the ischial spine. The littler thing underneath it is the lesser sciatic notch, which will bring us down here to the ischial tuberosity, the bump at the back of your butt. As you notice, there is not too many holes in this half of the pelvis. The only one hole that we have is called the obturator foramen. It is a giant hole, and it actually will have some tendons going through it. The pubis bone, as I kind of work my way around here, there's going to be an inferior ramus, and there'll be a superior portion here. And then on the other view, which will be the medial view, you can still see the obturator foramen. You can see the bump at the back of your butt, which is the ischial tuberosity. And then you can see the ischial ramus here. And it's all helping to make up this circle here. So the pubic bone, we're going to have the superior pubic ramus, and it comes to a point here called the pubic tubercle. And then this portion right here is a little bit wider on this side because we're going to put a pad of fibrocartilage in between that half and the other half, and that's called the pubic symphysis. It's called the pubic crest here. I think you can see it on this portion. So this is called the pubic crest right here. And so you're going to have the superior pubic ramus, you're going to have the inferior pubic ramus, and it'll meet up with the ischial ramus, making this circle here, which is called the obturator foramen. On this particular side, which is the medial side, you can see that here is the auricular surface, which is going to form a joint with the auricular surface of the sacrum. So we're going to put the two ears together, and by doing that, we're going to make a sciatic notch, or excuse me, SI joint, sacroiliac joint. That's where the two of them get together. The indented portion here is called the iliac fossa, and on the other side, the posterior portion is going to be the posterior gluteal lines and stuff like that. This is where all your gluteal muscles will attach to, this portion right here. So that takes care of the hip bones. You just have to be able to go around in a circle and be able to point out a IIS, a SIS, PSIS, PIIS, and know what those terms mean, because you can't use abbreviations during the test. That brings us to here. How can you tell if you're watching something on TV and they find the skeleton of this person? How can you tell a female from a male? Well, actually, if they can find the pelvis, it's really easy. So the pubic arch on a female is a lot wider, about 80 to 90 degrees, whereas a pubic arch on a male is going to be about 50 to 60 degrees. You can actually see that without having to know anything. And if you look at the wider portion of the female pelvis versus the narrower portion of a male, mostly that's all due or for childbearing. And so if we go here, you can kind of see little junior, if is in mom, he has a bigger area here to live in versus this portion right here on a male, because the sciatic knot, greater sciatic notch is going to be wide and shallow, whereas on a male it's going to be narrow and deep. This one here really shows it well. Here is the pelvic inlet, and there is where the baby would drop out of. You can kind of see it's a bigger, wider area than this little narrow thing here that isn't going to do so well if you're having a baby. So one of the reasons that females have a different pelvis is for childbearing, which now brings us up to the femur, which is the largest, longest bone in the body. So the femur has a couple parts that you have to know. One is the head. The head of the femur is going to go into the acetabulum of the pelvis. And so the head then has a unique neck, because the definition of a neck is it's a narrowed portion under a head. And in this particular case, you can definitely see here's the big bulbous head and a narrowed neck here on both of them. Then we're going to have the only place that you have a trochanter is going to be this big bump here, and it's called the greater trochanter, whereas the littler bump is called the lesser trochanter. Then we're going to have a crest of bone attaching the greater to the lesser, and on this side here, it is called the intertrochanteric crest. So basically, the name of this is just telling you where it is. It's in between the two trochanters, and inter means between, and so the intertrochanteric crest on the posterior side is a big bulge of bone. Whereas on the anterior side, you just kind of have a line, and that's between the greater trochanter and the lesser trochanter, and it's called the intertrochanteric line. As you follow that down, down the shaft, there is a shaft here on the posterior side. There's going to be the only line that is actually pronounced line, but it's pronounced in Latin, which is linea, and it's called the linea aspera. So underneath this knob of bone here, your gluteal muscles will attach here at this roughened area, which is called the gluteal tuberosity, which is very similar to the deltoid tuberosity that you had in the humerus. So there is some similarities between the upper and lower extremity bones. If you find the head once again and drop down here, this part here is going to be the medial epicondyle, because it's on the same side as the head, and here's the head, and so you'd see the medial epicondyle here. The other part that you would have here is a pointy part that sticks up, and there's a bunch of muscles on the inside of your thigh called the adductor muscles, and this little tubercle here is called the adductor tubercle. When you get to the medial and lateral condyles, these are going to sit on top of the tibia, which is the next bone or your shin bone. So if you find the head, this is called the medial condyle. On the other side would not be the medial, that would be the lateral condyle. So here is the medial epicondyle. Remember, an epicondyle is part of a joint, but not, it's near a joint, but not part of it. So this would be the medial condyle. This would be the lateral condyle, and then in between the two of them, it makes kind of a notch on the posterior side, and it's called an intercondylar, meaning it is between the two condyles, and the word they now use instead of notch is called fossa. On the anterior side, we're going to have a little groove here, and the little groove there is called the patellar surface, and the underside of this little pan, which is called the patella, has a area that will ride in this groove. And so the underside of the patella rides into the patellar surface, and if everything goes well, you're going to allow you to kick out your lower extremity and be able to extend your leg. So the only other thing that I didn't mention is there's a little pit at the head of the femur, and that is called the fovea capitis. So that covers all of the parts that you would have to know for the femur. The medial and lateral supracondylar lines, don't even worry about them. I'm not going to ask you them at all. And you can kind of see how these are all going to be put together. Here is the femur coming down. Here is the patella. And the femur lines right up with the tibia. The fibula is just along for the ride. It is not a weight-bearing bone at all. As a matter of fact, it's just going to hold your tarsal bones in place. So the next bone that we're going to deal with is going to be the tibia. The tibia is a weight-bearing bone because the femur would be right here, and so it would go right down to here. Now, because this one does not have a head, you can't really tell you whether you have a lateral or medial side. So you have to go down to the ankle. Down here is the medial malleolus. If you feel on your own body, the inside bump of your ankle is what you're feeling is actually the medial malleolus. So this medial malleolus lets you know that this portion right here is the medial condyle, and the other side would be the lateral condyle. Now in the tibia, rather than an indent, we're going to have something sticking up kind of like a crown, and so between the two condyles, it is called the intercondylar eminence. Let me see if they got a better picture of that here. And you can kind of see, here is the anterior view. Here would be the lateral condyle. Here would be the medial condyle. And here is this intercondylar eminence that is sticking up there. That's kind of holding your kneecap or your femur in place. If you come from that bulge of bone down to this here, the tibial tuberosity is where your quadricep muscles will attach to your tibia. And so it sticks out. As a matter of fact, it sticks out far enough where if you're some sort of skateboarder dude, it may stick out close to an inch, which is really painful if you're trying to kneel on it because it's going to have skin, then it's going to have a big knob of bone, and all of your weight is kneeling on that. That's why people who do tiles and kneel a lot usually will kneel on a pad of one sort or another. So if we follow that down here, this portion here of your tibia is called the anterior border, and that is what you usually kick furniture with your shin, or at least I do. So the anterior border is a pointy portion that is coming from the tibial tuberosity down. And then as we go from the medial condyle, we have the medial malleolus. And if you look at this thing here, it's kind of a notch here that's going to hold your tarsal, your ankle together, your talus actually specifically. So as we go from here, we're going to put this bone, which is the fibula, right next to the tibia. And so the same way that we did it with the ulna and the radius, you want to have a little indent here so that the head of the fibula can be right next to it. And then down here, the fibula only has two parts. It's going to be the head and the lateral malleolus. The lateral malleolus is going to be the other part that's holding the talus in place so that you can have a bend of your ankle. But if you look at this little circle here, there is going to be a joint there, which is going to be what's going to have your talus holding it in place. Let me just go back to this particular picture here. So when you have the fibula, which looks like a witch's stirring rod when they're mixing up a brew, it's a really, really long, thin stick. And it's going to have to be right next to the tibia. So by doing that, we're going to have this little notch here that in a few minutes I'm going to show you the talus, because that's what bone is going to be held in place there. But the inside bump of your ankle is the medial malleolus, whereas the outside bump of your ankle is going to be your lateral malleolus. If you were to look down and try to take the bottom of your foot and turn it so that it's going towards your midline, you can do that quite easier than trying to take the bottom of your foot and turning it out laterally. The reason that it is so difficult to turn it out laterally does not have anything to do with stiffness. It has to do with the fact that the medial malleolus is higher up than the lower hanging lateral malleolus. So everyone, even if they're flexible or not flexible, can turn the bottom of their foot, which is called supination, in a lot more than you can take the bottom of your foot and turn it outwardly, which is called pronation. So let's just get to the metatarsals. So the tarsal and the metatarsals are very similar to the carpals and the metacarpals. And so, although it's not two rows of bones, in this particular case, if I start here, because the first metatarsal is your big toe, so that's going to be 1, 2, 3, 4, 5. Once again, they use Roman numerals to tell you which one you're at, but the big toe is this one here. And this would be the first metatarsal. This would be the second metatarsal, third metatarsal, fourth and fifth metatarsals. So the first metatarsal goes to this row of bones, which is going to be called the cuneiforms. So the first joint is going to be the medial cuneiform, because this is going to be the medial portion and the little toe is going to be out laterally. So you have the first metatarsal going to the medial cuneiform. The second metatarsal will go to the intermediate cuneiform, and the third metatarsal will go to the lateral cuneiform. So first, second, third metatarsals will go to the tarsal bones, which are your ankle bones, medial cuneiform, intermediate cuneiform, lateral cuneiform. And just as though we had the fourth and fifth metacarpals go into the hamate, in the ankle and the foot, we're going to have the fourth and fifth metatarsals going to the cuboid. So 1 goes to the medial cuneiform, 2 goes to the intermediate cuneiform, 3 goes to the lateral cuneiform, and fourth metatarsal and fifth metatarsal go to the cuboid bone. These three cuneiforms in the next row will line up with the navicular, and then the navicular will go to the talus. The talus, remember, that's what's going to be held in place by, on this side would be the tibia and the medial malleolus, and on this side would be the lateral malleolus of the fibula. And then the cuboid and the navicular will match up with the calcaneus, which is going to be your heel bone. So that takes care of all of the tarsal and metatarsals. As we go out here, same way that we had with our hand, we are going to have a proximal and distal for your big toe. Your big toe bones are as big, if not bigger, than most of your hand bones. So the proximal phalange or phalanx of the first digit would be this one, and the distal phalange of the first digit of your foot would be this one. These are all considered to be long bones, even though they're really short and stubby. So of the first metatarsal would be, this would be the proximal, this would be the distal. For the second metatarsal, this would be proximal, middle, distal. Same thing with third, same thing with fourth, and they have it labeled here for your little toe. This would be the proximal phalange of the fifth metatarsal. This would be the middle phalange of the fifth metatarsal. And then your little itty bitty toe, which has probably been broken, would be the distal phalange of the fifth metatarsal. So you can see 3, 6, 9, 12, 13, 14 phalanges are the bones that make up your toe bones. And then, of course, if we add into the metacarpals or the metatarsals, we would have 19 bones that are making up your toe bones and your forefoot. And the same thing with the wrist would be, you would have 14 phalanges making up your finger digits, and then you'd have the 5 metacarpal bones. Once again, that makes 19. So each hand and each foot has 19 bones in it, so that's 38. And then you have 2 pairs of them, so that's 76 bones. So with the tarsals and the carpal bones, you got close to 100 bones of your 206 bones that will be making up your feet and your hands. Just, you know, the number that you think about. And once again, for the hand bones, it's going to be responsible for manipulating your environment. Here is another view, a medial view, looking at it from the big toe side and what you were going to look at as the bone-wise. So here is the big toe, the first metatarsal. It goes to the medial cuneiform, which goes to the navicular, which would then go to the talus. And since this is medial, this side here would be the tibia side, and so hanging down here would be the medial malleolus, and then it would go to the calcaneus. Here's the lateral side, looking at it from the little toe side. Once again, you're going to have first, second, third metatarsal tarsal would go to the lateral cuneiform, and then the fourth and the fifth metatarsal would go to the cuboid. The cuboid would then go to the calcaneus. And on this side, the lateral malleolus, or the fibula's long hanging down thing, would be on this particular side. Some of the arches at the foot, although we're not going to ask you anything about it, just so you can see it. The idea of your foot is to have kind of an arch. So your forefoot would be on it and your heel would be on it, and then there would be an arch there. On the lateral side would be the lateral longitudinal arch, and on the big toe side would be the medial longitudinal arch. But there also would be an arch going from side to side, which is called your transverse arch. That takes care of all of the bones of the lower and upper extremity, and good luck studying it.